Hello, welcome to the session. My name is Ricardo Rodriguez. I'm the current president of the IFATS, is the International Federation for Adipose Therapeutics and Science. We are a society that's purely dedicated to studying adipose therapies, including everything from fat grafts to SVF. We just had our annual meeting. Our next annual meeting is in San Diego. Next year. I left you all some flyers out here. If you're really interested in adipose tissue regenerative therapies, this is the place where all the leading scientists in the world meet. So the first lecturer today was supposed to be Bruce Bunnell from Tulane University. However, he had this weekend is receiving another major award, so he could not make it. So he sent Ann Bowles. And I have another correction to make. Adam Katz, who was the person who originally discovered mesenchymal stem cells in adipose tissue, was scheduled to talk, and he also couldn't make it. And he was actually going to be the one talking about 3D cultures, so the 3D cultures is not going to be included on this lecture. Anyways, without further ado, Ann Bowles, she's a PhD candidate under Dr. Bruce Bunnell at the Center of Stem Cell Research at Tulane University, and she's going to talk to us today about some of the things we can do with SVF rather.
Thank you. All right, so I would like to thank all the organizers for this conference and allowing me to present on behalf of my PI, Dr. Bruce Bunnell. Unfortunately, for him isn't able to make it, but fortunate for me, I'm able to stand in his place. But I will talk about stromal vascular fraction and adipose-derived stem cell-based therapy. I first want to introduce the stromal vascular fraction, or SVF. Initially, when white adipose tissue is harvested, it undergoes a mild digestion procedure. After this digestion procedure, the adipose tissue is centrifuged into 3 layers that are able to be acquired. The top lipid layer is the mature adipocytes and the lipids, the middle aqueous layer, and the stromal vascular fraction pellet at the very bottom, which typically is plated and culture expanded to obtain the homogeneous population of adipose-derived stem cells, or ASCs. And many clinical applications have been proposed using ASCs, and many results have been evaluating the safety and efficacy and uses of ASCs for many clinical indications. And knowing that the advantages of using ASCs, knowing that the ASCs are within the SVF, looking at the SVF is one of our focuses in our lab, and looking at and evaluating the safety and efficacy of this more fresh product, the more crude heterogeneous cell population of SVF. With flow cytometric analysis, we looked at the several different subpopulations of SVF. This in particular is through our isolation and our method of isolation, and also filtering to obtain these cell populations, the majority of that being the lymphohematopoietic cells, or the CD3 positive cells, the ASCs within that population. So these two are the large majority that compose the SVF. The adipocytes, preadipocytes, endothelial cells, and smooth muscle cells, and to a lesser extent, cells that have matured and have are of the myeloid and lymphoid cell lineages. Looking at the applications that are currently used with SVF is to enhance fat grafts, so fat grafts that have been used for many different cosmetic and reconstructive procedures, where a fat graft is supplemented with freshly isolated SVF and is typically administered straight back to the patient, known as also cell-assisted lipotransfer. But using these studies where they have demonstrated safety and efficacy, and perhaps some other mechanisms and indications of these mechanisms where SVF is more beneficial than just using the fat graft alone, has led us into our investigations. Currently in the United States, there are recruitment of clinical trials for multiple sclerosis and osteoarthritis, but much evidence for using SVF has come from many veterinary medical applications where many horses and dogs and other animals with bone and soft tissue disorders have been treated with no adverse effects reported. And more of my field of study, looking at the murine models of neurodegenerative diseases, autoimmune diseases, and inflammatory diseases. Altogether, these studies have given us good indication that the SVF administered as therapy is safe, it ameliorates pathology, it attenuates disease, they are anti-inflammatory and potently immunomodulatory, and perhaps promote tolerance. And this is all very important for many neurodegenerative diseases, which I will go into. So talking about how this translates to human patients, multiple sclerosis or MS patients. MS patients are about over 2 million people worldwide, making it the leading neurodegenerative disease affecting young adults, typically ages 20 to 45. And it's believed that a genetic factor is incited by an environmental component that instigates an autoimmune reaction against myelin, which is an essential component of the central nervous or CNS tissues. Now, this myelin is produced by oligodendrocytes and creates a sheath that wraps around nerve axons for normal neurotransmissions. Now, when this autoreaction happens, cells of the periphery of the lymphoid tissues are primed by this antigen as foreign and then go into the peripheral blood, circulate, break down the blood-brain barrier, and infiltrate into the central nervous system tissues. And here, the cells not only encroach on the CNS tissues, but they generate these inflammatory and demyelinating lesions. And depending where these localize, patients with MS produce signs and symptoms of disease such as cognitive and motor impairments, fatigue, spasticity, and progressive paralysis. Now, most MS patients are first diagnosed with relapsing remitting disease, but since this remains an unmet clinical disorder, and many of the current disease-modifying drugs out there are acting systemically, targeting only inflammation, and also have neutralizing antibodies such as interferon beta. Many of these patients, in most of these cases, develop a more chronic and progressive form of MS. Now, recapitulating these immunological, neurological, and pathological features of MS, the best model out there is the murine experimental autoimmune encephalomyelitis, or EAE, mouse. Now, this mouse develops a T-cell mediated autoimmune disease by the administration into the subcutaneous flanks of the tail of the myelin oligodendrocyte glycoprotein, which is emulsified with an adjuvant and tuberculosis. And concomitantly with this administration is an intraperitoneal injection of pertussis toxin on the date of induction and as well as 48 hours later. Now, this is the typical immunopathogenesis and how it is graphed in our form, where we look at the severity of disease, which is daily clinical scoring. Looking at the score of 1, which is some gait abnormalities, which progresses into a score of 2, which is weakness of the hind limbs, a score of 3, which is partial paralysis of the hind limbs, and a score of 4, which is complete paralysis of the hind limbs. And as you can see here, signs of disease are apparent after 4 to 5 days post-induction of disease, which is on day 0. And looking at this overall progression, looking at in the red is our EAE mouse compared to the sham, which is in blue. As the disease progresses, this is all a result of the breach of the blood-brain barrier, infiltration of the immune cells into CNS tissues, and a widespread inflammation throughout the CNS with inflammatory and demyelinating lesions. As you can see here, the lesions are demarcated by the black arrows. Going back to what we've known as a utility of ASCs, and now that stromal vascular fraction, or SVF, contains those ASCs and have similar benefits, we would like to look at other properties. We know that ASCs are able to differentiate into cell lineages like most other mesenchymal stem cells. They're able to renew, and they also produce anti-inflammatory and immunomodulatory effects that are therapeutic. But more importantly, I would like to we would like to look at the capacity of SVF and ASCs to be able to migrate to these damaged areas on their own, provide immunomodulatory and anti-inflammatory effects and trophic support there at the sites of damage, and see what other mechanisms that they are providing as a therapeutic benefit. So a little about the experimental design. Here I identified again the scoring system that's used for the daily clinical scoring. And throughout this 30-day trial, all of the mice undergo motor function tests, which here you can see is a top-down view of our video recording, which is 5 minutes each of each mouse. The mouse is then detected by movement using an EthoVision by Noldus Technologies, where a lot of these parameters, motor-based parameters, are able to be generated and analyzed for a quantitative comparison. Throughout the 30-day trial also, researchers will allow for behavior and motor function testing as well, which includes rearing behaviors and grooming behaviors. And at the end of the trial, which is day 30, tissues are harvested. Our tissues of interest are the lymphoid tissues, which are the lymph nodes, the spleen, the blood, as well as the CNS tissues. For this particular study, we're looking at the late-stage therapy. How effective is SVF after pre-existing pathology? So this translates to also with humans with pre-existing pathology and how reparative these cells can be. So the groups that we were able to design for was the SVF-treated EAE mice that receive 1 million SVF cells, ASCs, 1 million ASCs were administered to the ASC-treated EAE mice and the vehicle controls. And looking at day 20 is when we decided is our late stage therapy. Again, pre-existing disease with inflammatory and demyelinating lesions already occurs at this time. So we ultimately want to answer the question, what is the efficacy of SVF treatment at late stage disease? And more importantly, what are these mechanisms that are being harnessed by SVF? And that way we have better indications and better evidence for something that can go translationally. Looking back again at the daily clinical scoring, day 20 is the time of injection of these cells, whether it be SVF, ASCs, or vehicle. And as you can see here in the green, which is the amelioration of observable disease signs, is from the SVF treatment group. ASCs is in the middle with the blue squares, and then in the red is our vehicle control group. Looking at the mean score and cumulative disease scores, we can see that there was a reduction of the disease scores, meaning that there is amelioration of these signs of disease. Anywhere from 20 to 30 days, this was quantified. Looking at the behaviors, unprotected rears, the wall leans and grooming bouts, all of these behaviors really require a lot of balance, coordination, and motor function. So it's very important to note that our vehicle-treated mice were unable to execute any of these during the 20 to 30 days post-induction, whereas the ASC and SVF-treated mice were able to, and significantly greater. Looking at this top-down view again, so this is the compiled tracks over 5 minutes of each of our mice, and there's a representative mouse here that is shown for each group. Looking at day 20, where in all groups, considerable amount of reduction of motor function is seen, as well as you can indicate some cognitive defects. Most normal mice like to scavenge the area several times, and it has a very even spread, whereas these mice with disease perhaps forget where they're going, or they are just not able to go and go into this wide motor function. The ASC and SVF mice do represent or do show that there is recovery of these motor functions even 5 days after the injection of cells. This is the gating strategy that's used for the next couple of slides, looking at the how identified the different cell populations in these other tissues that we investigate in order to look at the immune system activities and how were these changed with the administration of cells. Looking at the peripheral blood, spleen, and lymph nodes, these tissues were put into a single cell suspension and stained and analyzed with flow cytometry. Now there were similar trends with all three of these tissues, but there were significant alterations in the immune cell populations in the peripheral blood. Again, this is the communication between the peripheral lymphoid tissues and the central nervous system. So what cells are there, what's being migrated can all be inferred from this data. Looking at the total T cells here, which to the subpopulations, the helper T cells, these were significantly greater or increased with SVF administration, as well as of the myeloid population, the macrophage population. Looking at the spleen analysis of these same populations, we have the lymphoid cells, the T cells, and the B cells, as well as the macrophages, were all significantly greater in the SVF-treated spleens of the EAE mice. A similar trend here in the lymph node tissues, but most importantly, here we are able to detect regulatory T cells. So this is something that we were not able to look at, we never got results for before, but with SVF treatment, we see that there is regulatory T cell induction in the lymph nodes, and this was significantly greater than the vehicle or ASC group. So this is where there's some kind of distinguished effects between ASCs and SVF that we are able to see. As most of you know, regulatory T cells are the good T cells. They promote immune tolerance. They want to counter the autoimmune effects that are happening in vivo. Looking at the central nervous system tissues, this is particularly the spinal cord sections of the cervical section. Cellular infiltration in myelin was able to be quantified using stained sections of H&E and Luxol Fast Blue respectively, and these were quantitatively compared. Looking at the total cells per field for the cells that have infiltrated into CNS tissues, the ASCs and SVF had a significant reduction compared to the vehicle-treated mice, whereas the myelin levels, which were higher, significantly higher in the ASC and SVF-treated mice. So perhaps there are some remyelination, or perhaps the SVF or ASCs are inducing some kind of precursor oligodendrocytes to restore the deficits that have already occurred in the CNS tissues. And then analysis of the inflammatory lesions. As you can see in the images, they are manually depicted, and then they're quantified by the surface area and number of lesions using ImageScope software. And as you can see here, there's a significant reduction with cell therapy in the number of lesions and the surface area. Looking at the gene expressions in the spinal cords, interleukin-10, which is produced to induce T regulatory cells as well as is produced by T regulatory cells, is significantly, or I'm sorry, not significantly, but there's a greater increase with the SVF treatment, as well as interleukin-6, which is one of those pleiotropic cytokines, which we believe is beneficial in this mouse, in this disease. Here also, similarly with the brain analysis of the gene expressions, looking at IL-10 increase and IL-6 increase with the SVF treatment. Looking at the serum levels, we had an ELISA to look at particular cytokines, and there was a reduction in the inflammatory ones and an increase in the IL-10. With in vitro proliferation assays, we're able to look at modulation of the immune system, where we re-stimulate these cells with the MOG antigen again for the second exposure. And as you can see here, SVF did not have a proliferative response, suggesting some very potent immunomodulatory effects. So ultimately, we believe this is a very comprehensive treatment that would be very efficacious for EAE mice, as well as these results will translate for the human MS disease. We saw improvement with motor function, behaviors, as well as restoring a lot of the deficits that were in the central nervous system tissues. So we support the use of SVF as a promising therapy for MS patients with pre-existing disease. And I want to thank my lab, as well as the Dr. Jeff Gimbel's lab, who is a close collaborator of ours, and thank you.
Thank you very much. Thank you. The next speaker I want to introduce is, we'll hold questions till the end of the session, is Dr. Bill Cimino. Dr. Cimino has 30 years of experience in research and product development in the medical industry. He has 3 engineering degrees, including a PhD in bioengineering. He is currently the CEO of the GID Group, a leading adipose tissue and science and technology company. I've actually used this device in my own research. I love it, and I recommend it to anybody who's doing research as a quick method of getting SVF. Anyways, Bill, you take it.
I appreciate and thank you, Ricardo, for the invitation. I'd like to address really working from adipose tissue. I'm going to start with the anatomy and work all the way to clinical results. We've got several clinical outcomes I'd like to share with you, but I always start with the anatomy. And the magic of adipose and stem cells and stromal vascular fraction and all these words that get used all come from here, and I want to make sure there's no confusion. Basic adipose, we have the adipocytes. You see the little fibrils. This is our extracellular matrix. We've got the vascular structure, and attached to all of that, mostly to the vascular structure in the extracellular matrix, we have this host of heterogeneous mononucleated cells called the stromal vascular fraction. So fat, when we start with a fat graft, we start over here. We have the adipocytes, we have the extracellular matrix, we have the vascular structure, we have the SVF. Part of the SVF is what we call the ASCs in a previous talk. So here we have SVF as a subpopulation, and I'm speaking specifically of only the mononucleated non-floating cells. And from there we have a subpopulation, which is the ASCs, which are the by markers 45 negative, 34 plus, 31 negative, which would be our progenitor cell fraction. And that is 10 to 15% of the stromal vascular fraction by count. So if we look at adipose by volume, and between these 2 or 3 slides, everything flows from this. Fat is, by the way it is, 85 to 90% by volume is adipocyte. Varies from men to women, varies from site to site, but largely speaking, it's the majority is adipocyte. Whole fat is about 10 to 15% ECM plus vascular structure, and less than 0.5%, that would be the maximum, would be all these stromal vascular cells concentrated. If you take whole fat and you excise it, you can get somewhere between 2 and 4 million SVF cells in the perfect condition. That's how many would be there if you could get every single one of them. And of those cells, like I said before, 10 to 15% is ASC. So let's talk about fat versus SVF versus ASCs in a sort of a hierarchical understanding. Fat grafts do contain SVF and ASCs, and there's a lot of people that say they're doing stem cell grafts or fat grafts. Yes, there is SVF and ASC in fat, but the concentration is very low by volume consideration. It's not concentrated. The adipocytes, which are the majority of that, are not regenerative. They're useful for constituting volume or initiating a fat graft layer, but they're not the regenerative cells. SVF starts here and gets rid of the adipocytes, the extracellular matrix, the vascular structure, and you end up with a heterogeneous population of ASCs, a heterogeneous population called the SVF, of which 10 to 15% is ASC, and importantly, all the adipocytes and RBCs and oil droplets and cell fragments are gone. ASCs start here, and we plate them, we culture them, we expand them, and you go further and you get sort of a homogeneous ASC progenitor population with no adipocytes or ECM. It's a picture of a nice cell pellet. This is not spun hard for those of you who are used to test tube hard spinning. This is, if you look very carefully, these pictures aren't too clear, but the RBCs and some of the lysed hemoglobins at the very bottom, if you spun this harder, you could separate it out into a white and a red layer. Maybe the most important slide I'm presenting today on the issue of concentration of regenerative cells. Concentration of regenerative cells is the issue. We need to get these cells. In a fat graft, you've got a relatively low concentration of about 2 to 4 million SVF cells per gram or mil of whole fat. Of that, there's going to be some ASCs at the 10 to 15% population. SVFs, because you can now take the cells and concentrate them, are between 100 and 200 million SVF cells per mil or gram, about 50 to 100 times that of fat. Okay? The ASCs follow form by 10 to 15%, 10 to 50 to 100 times that of fat, and then ASCs obviously are a 100%, roughly speaking, concentration of ASCs. You can get about between high and low 60 to 300 million cells in a gram with fluid. Okay, so how do you get SVF? Three major ways. One that we know most about is the enzymatic method. It's been studied the longest. Most is known about this. And the beauty of the enzymatic method is the collagenase is highly specific to the collagen structure. So it is specific to releasing these cells, and it takes about 60 to 120 minutes depending on what method is going on. And the vast majority of that time is where the enzyme is working on the extracellular matrix. There's a lot of mechanical methods that are being looked at. There's blenders, meshes, shakers and centrifuges, metal balls. These are mechanical impact and disruption of the adipose tissue to attempt to release the stromal vascular fraction and cells that are bonded into the ECM. It takes less time, but you have the impact of mechanical damage on the tissues. Explant culturing is also used where we culture whole tissue, and as the cells become apoptotic, they start to migrate off of the extracellular or vascular structure and into the culture medium. This takes 3 to 7 days, depending on what's going on. The key to all of these is really an efficiency. How many cells can I get per gram of fat? I don't have an infinite source of adipose, and how many can I get? Enzymatic is known. And if I went back through the past 20 years, it started at 200,000 cells per gram, then it went to 400, and depending on your process, we're typically running about 1 million cells per gram of fat, but it can fall, and it varies with patient, 500,000 to 1 million cells per gram of fat with a high viability of 75 to 80%. This viability is by way not compromised so much by the enzyme. So leaving exposure to the enzyme, the viability is maintained. A lot of this viability is lost in the harvest process, and that's what you see here. CFU analysis is strong, over 5%, and as I said before, it's highly specific. The collagenase is highly specific to release of these cells. Mechanical tends to be less productive with regard to yield. I'm looking at 10 to 250,000. This is widely reported. Our experience is towards the lower end, but the big concern that we have in this analysis, it works both ways. I'm not commenting too much other than the reality is we tend to see very low CFU performance, and we do see viabilities down towards 50%. Explant culturing, obviously you get highly viable cells. They're replicating. So to have a major clinical impact, we need some way to get from body fat over to science and research, and that process needs to be fast, reliable, and safe. So what we've been working on is a system that is usable in an OR, has quality control system, processing time less than an hour, and so you can put tissue in a sterile field into the device, and when it comes out of the device, it is the cellular structure that you're looking for. Works something like this. It's not any different than a lot of other systems, other than it's been optimized for simplicity and effectiveness. Harvest, a washings phase, enzymatic digestion, a centrifuge phase, extract the cell pellet back to the patient. Very direct. In our first major commercial effort, we had a product called the SVF. This is the total time frame. We got it down to 60 minutes. The majority is dissociation in a shaker and removal or a centrifuging of 50 of the 60 minutes. We're currently working at about 42 minutes tip to tail. So from harvest to re-injection of the patient is now 42 minutes. This is what it looks like. This is another device where we have a stromal vascular fraction extracted into 2-3 cc syringe for an orthopedic injection. Important piece here, this is what the extracellular matrix and the vascular structure look like. We retain it in a mechanical structure and a mesh. The cells have been released from this, and this is what the goo looks like after it's been largely dissociated. With regard to performance, over the years we've had several independent groups and studies. This is 700,000, 950,000 cells per mil of fat on average. That's what our SVF yield is. We're currently running right there at 1 million SVF cells per gram of fat. Viability is running 75 to 85% consistently and reliably. This is the age curve, what happens to fat as people age. Same plot, both sides. Linear regression to the downward direction. The important point here is the younger patients obviously have a much higher yield, and they're wonderful with regard to cells, but it's 800 to 1,000, whereas by the time you're over 60, it falls, but it only falls to about 500,000 cells per gram of fat. Enzyme concentration is a huge topic with regard to regulatory environments. I don't want to bore you with all these numbers. Needless to say, collagenase can be easily removed from its dissociation with 1 to 2 dilutions. We generally run about 5 CDUs per million cells. So a 20 million dose would have between 50 and 100 CDUs in a dose, and a CDU for just to be quantified is 1,000th of a Wunsch unit. So we're running around 0.05 to 0.1 Wunsch units in a dose, which is 99% removed from the initial concentration to dissociate the tissue. Clinical applications, really the best part. We focus in 3 areas. The orthopedic area, primarily osteoarthritis, but also ligaments and tendon repair, wound care, and then some aesthetic breast reconstruction surgery. I've got examples of all 3. The osteoarthritis trials are not pretty to look at because there's no results to look at other than to tell you that they were small safety trials, a 3-month and 1-year follow-up, single injection of SVF of 2 to 3 mil. And the patient was its own control under IRB. These have both been published in their respective journals. These are available online and in the journals. I'll summarize the first trial here. This is pain intensity. This is what's called a PROMIS pain scale, pain interference, pain behavior, all things related to what I'll follow up with a WOMAC, all declining. 10 of 10 patients improved with decreased patient, and here's the big one. 7 of 10 went from their initial osteoarthritic pain to 0 pain at 3 months. And this was statistically significant. The second trial was 1 year long. We had the same, these are 2 different scales. This is what's called the WOMAC, very common in orthopedic realm, VAS scores, visual analog pain scale. Measuring the same thing, I'll just talk about this one. 8 of 8 patients decreased, and 6 of 8 had a WOMAC score of less than 10 at 1 year. Statistically significant. A score of less than 10 is phenomenally low pain compared to initial scores. So the summary of the 2 trials, 18 knees, 2 independent trials, 17 of 18 patients had decreased pain at 3 months, and 8 of 8 who we followed out to a year had decreased pain. These 2 trials are now involved in a full FDA IDE level 1 blinded randomized trial. Peripheral vascular disease. These pictures are pretty graphic if this is not your bent. We did a 10-patient trial in Nicaragua where all patients were slated for amputation. So these are bad diabetic ulcers. This patient is a 57-year-old female. You can see the condition. This is 3 months post-excisional surgery, so no cells have been used. This is just getting rid of, getting the wound ready for cellular treatment. So this is 3 months after this, and you can see the condition of the wound. At that point, she was treated with cells under the wound and also down the lower vascular structure of the lower leg. So we were working on the vascular flow in the leg. This is 4 months. This is 4 months here, and this is spontaneous and complete closure at 8 to 9 months. This woman was going to have her foot cut off. We had no other way to do this. We have 10 patients in a row like this. I'll show you the second. This is also peripheral vascular disease. You can see the condition, 75-year-old man, same conditions. He was treated with cells in the excised area and also down the leg the same way. This is what it looks like at 6 months post-therapy, and there's complete closure at 8 to 9 months. So we have a series of 10. I won't go further. I'm going to talk about burns, also done in Nicaragua. This was a significant burn to the right arm, a kitchen wound. She had had 10 surgeries to release the contractility and the scars. After 6 years, she still could not oppose her thumb and her fingers. These 2 were locked together, and she could not pick up a piece of paper, a pencil. She could not write, and she had consistent pain. We treated her with a little bit of fat to the back that was enhanced with SVF. We put a half a cc of cell-enhanced lactated ringers and cells in each joint, the same way we treat the knees. And this is her hand at 3 weeks. This picture, it's important to realize, is pre-op. This is as far as she could open her hand. This is what she could do at 3 weeks, and we could begin to pick the skin off the back of her hand, meaning like this, where she was scarred down before. This is, I'll play this for you. I don't know how to do this. This is her. How do we make that go? Touch it? Yeah, I'll run over, so we'll do this. She shows you, she's a journalist in Central America. that how she could type. So she was doing, for 6 years, she could only do this because this is the only thing that would work. And then she shows you that she can use the full hand, and she types. And she, more importantly, she's pain-free. From breast, this is on the left side. You can see a congenital malformation here. This was augmented. It looks like this. That patient is now 3 years out with no loss of volume. Same thing here. This is a standard breast augmentation pre-op, and this across the top post-op, and the volume is now over 2 years and retained. So those patients are all, or not the burn, but the breast patients are published in this paper, 74 patient series. Skip the regulatory, it's a complex and involved issue. The point was to be able to, and I'll conclude with this, to be able to go from an operating room all the way through therapy in less than 1 hour in cellular treatment. And these are 3 areas that we've been working. So with that, I'll conclude. Thank you.
Like a true efficient engineer, a lot of material in very little time, very well expressed. Next is Dr. Camillo Ricordi. He's a Stacy Joy Goodman Professor of Surgery at the University of Miami, a distinguished professor of medicine, professor of biomedical engineering, microbiology, immunology, and the director of the Diabetes Research Institute and Cell Transplant Program at the University of Miami. But forget about all of that. What impressed me the most of him are his pictures with the Rolling Stones when he was young. That's his.
And this is the pointer. So, how many people were here yesterday for my presentation? Not a lot. Okay, there is a little mixture. I wanted to give a little at the beginning to show you a different perspective of using adipose tissue in cell therapies, which is using at the site of cell transplantation. And this is a review article that I mentioned yesterday, has summarized the 25 years experience in islet processing and transplantation for your enjoyment. And this is this engineering of a mini pancreas, mini endocrine pancreas intra-abdominal that we've been working on at the University of Miami and with collaborators worldwide to use as a platform technology to include, besides insulin-producing cells, also other cell types that may help induce intolerance, immunomodulation, so MSCs, Tregs, as well as conformal coating encapsulation to introduce barrier technology. This is, I just mentioned because we did the first patient last August, and the procedure is practically seeding using a biological scaffold, fully resorbable, comprised of autologous plasma from the recipient's own blood, human recombinant thrombin, and islets. Here you see a cluster. These are like less than 0.5 millimeter in diameter. You mix them with autologous plasma, seed them by laparoscopic surgery in the omentum, then drip human recombinant thrombin, an additional layer of plasma and islets, and then fold the omentum without any stitch and let them get revascularized by the omental layers. And this has been, the first results have been rather impressive. This was before islet transplantation on 31 units per day of insulin and huge glucose variability, glycemic variability, and especially severe hypoglycemia that is a reason for indication of islet cell transplantation. And this is after the islet transplant at the 3 months visit off insulin completely since the 2nd week with a very stable glucose control. This is continuous glucose monitoring system. So it's been very exciting, and now we're teaching other centers worldwide about this procedure to try to build up the numbers in the next few months. But the other reason you can use fat, as you heard, is that instead you can use it for regenerative medicine application and wound healing. This is how I got involved, is when Carlo Tremolada came to Miami to the Cell Transplant Center asking for help to characterize this cell product and why they were, and try to understand why they were obtaining better results clinically. Initially was done in plastic surgery application and cosmetic surgery to use smaller needles, and they practically what they did is to obtain a very fine adipose tissue preparation going through 2-cluster reduction with this system that has been developed then in a kit that is disposable, and you have it also here in the exhibit stand and is comprised by 2 filters, one a little bigger, like 4 millimeters, than 1 millimeter, and you practically pass the lipoaspirate product in a full immersion system. Let's see if I'm more lucky with this movie. So you pass the lipoaspirate through the first screen, first cluster size reduction, in full immersion without any air to avoid tissue damage, and then you agitate the solution inside the container to emulsify the oil residue and be able to wash them out by counterflow while the fat remains in the higher portion. Then you flip the cylinder, and now you have the smaller screen, 1 millimeter on top, and you aspirate saline from this bag and then push and harvest the product, the adipose tissue reduced cluster product, which is ready for clinical use. So the procedure lasts like 15 minutes or less, but is really simple. And the fact that you have a disposable kit, doesn't use any enzyme, doesn't require centrifuge or any specialized equipment in the operating room. If you look at confocal microscopy of this micronized cluster of adipose tissue, you can appreciate there is a huge presence of cells that are not adipocytes, that are the cells comprising the stromal vascular fraction and pericytes, endothelial cells, and all the cells described before. We've been collaborating with Bruno Peolt, the chairman of orthopedics at UCLA, and Arnold Kaplan in Cleveland, to try to understand mechanistically why this system works. And it seems that the hypothesis is that the pericytes that are lining all this microvascular structure that are enriched, you find twice as many in the lipogen product compared to lipoaspirate or whole fat in percentage. This may be important cells because they respond to injury being activated and producing MSCs with regenerative potential. So you all know the immunomodulatory and other properties, regenerative properties of MSCs. And this is one of these clusters of lipogems. If you put them in culture, they generate stem cells, and you can move towards advanced cell therapy with expanded MSCs from this cluster, but is not the primary use. Right now is used as a minimally manipulated autologous tissue, providing both a structural scaffold and activating pericytes. And this is interesting. Why I say activating pericytes? Because we seems in proteomics analysis that there are differences between the cells that are contained in the lipoaspirate or what comes out of the lipogem after the cluster reduction. These are studied by Bruno Peolt group that have been just recently presented, and without getting into the detail of the analysis, but if you look at the secretory activity of lipogem fractions compared to SVF, you see that you have many more markers, both for angiogenesis and cytokines. And then if you digest the lipogem with enzymes, you lose it. So use like enzyme digestion, reduce the secretory activity of the lipogen fraction. So this is just at the beginning of what we are trying to understand mechanistically of what could be some of the reason why this appears to be a better product in the hands of some. So this fact that this secretes in vitro multiple factors, growth factors, cytokine involved in tissue regeneration and repair could be important. Another factor that we found intriguing is that when you look at exosome and microvesicle content of lipogem compared to an enzymatically processed tissue, you find huge differences. Like the exosome are exactly the same as a particle size, but if you compare collagenase treated to lipogem, this exosome concentration analyzed by nanoparticle tracking analysis shows a big difference, very highly significant. So as you know, there have been now a lot of studies and hypotheses on how exosome may be critical agents in regeneration and regenerative medicine therapies. This is an excellent review if you want to check it out on the current landscape of MSC stromal cell secretome. and how this could constitute the base for maybe preconditioning we were discussing yesterday to trigger and target exosome and microvesicle that has specific functions that could help stem cell therapies as well. So clinical experience has been several thousand cases now as of June of 2015, both radiotherapy damage of vocal cords, incontinence, breast, face, colorectal, bone necrosis, femoral head necrosis, diabetic chronic wounds, and other application. This is all published, microfracture purified lipogem in orthognathic surgery procedure. Overall, 120 patients treated with this. I leave you, if you want to check the details of the studies, are on open access publication. This is a chronic hind limb ischemia study by Ventura and collaborator, also very interesting for the potential neoangiogenesis response of the lipogem treated tissue, where they showed that there has been, even in culture, in vitro culture, a big effect on HUVEC seeded on the bottom of the well place, and showing the results on lipogem treated versus even a combination of cells that were treated with different agents. So this is the same showing now arteriogenesis in ischemic muscle tissues. And this is another clinical application was recently published on the recovery of functional anal incontinency after microfragmented fat graft lipogems. And these are the site of fat injection. This is the manometry before and 1 year after. And this is important because apparently when you use single cells or expanded MSCs, the effect is transient. Well, here you see the defect, and then at 1 year down here, the fat disappears, but the muscle seems to recover. And here you see the persistence of the wax and incontinence score, in addition of the manometry data that I show. There are now several trials ongoing on diabetic foot ulcers, and these are 3 reference centers in Italy that are involved in these trials, and with very interesting initial results. And here is in orthognathic surgery data also published, so I'll let you go explore the details online, as well as regeneration in difficult case of oral surgery application. So it seems that there is an increased osteogenic potential of lipogem when you compare it to lipogem exposed to collagenase enzyme or digested fat, and this may have relevance for clinical application. As I mentioned yesterday, the whole system started from this racing horse that was treated, couldn't walk anymore, and was treated for a major chondropathy problem. And this is the, after the treatment, there was a, too bad these movies don't work, but anyway, this was the arthroscopy, the biopsy that demonstrated newly formed cartilage at the site of lipogem injection intraarticular. These are other examples in bone fracture that are delayed unions, severe pain at the fracture with no sign of healing 9 months after the fracture, and then after the lipogem application was a very good healing and complete recovery functionally. This is a femoral head necrosis cases that are now also undergoing clinical trials, where the lipogem is mixed with the hydroxyapatite. What's called that product that they use? Yes, calcium hydroxyapatite. This is another interesting application, especially for me, that I have 4 herniated disc following downhill ski racing when I was younger, and I was interested to see that now in 45 minutes they can do discectomy, fibrous ring ablation, injection of lipogem, transplant, and be done in 45 minutes. This is another new trial, potentially an application that will be very interesting to follow. Konrad Zlinowski in Poland has a huge orthopedic practice, and we're very excited to see the initial results in 60 patients treated for knee osteoarthritis that was confirmed by X-ray and MRI results before and followed then for now up to 1 year post lipogem injection with improvement of the symptoms, but also some encouraging results as far as MRI before and after lipogem treatment. This is another case 12 months after lipogem treatment injection with a reduction of the joint space narrowing that persisted for now over 1 year. And this, where was it? Yes, this is another MRI before injection and 3 months after lipogem treatment. So this is another interesting case, Triano. This is the beginning of a 100 subject IRB study approved by this institute, and this was the first case report from this trial showing as results. I'll just show the functional score improvement, the pain scale reduction with at 1 year practically virtually no pain, and also the evidence at MRI of increase doubling of the thickness, suggesting cartilage reconstitution from 0.75 to 1.5 millimeter of cartilage at 1 year. So in conclusion, it seems to be an effective solution for many clinical applications. It's very easy to apply and has an early anti-inflammatory and pain mediation, followed by effect on cartilage and bone that can appear after a minimum of 4 weeks and continue to improve for many months, usually beyond 1 year. So this is just the beginning of this experience. There are several dozens clinical trials now ongoing worldwide. It's been approved in Europe, USA, China, Australia, Middle East, and Japan. And as a matter of fact, Carlo Tremolada couldn't be here to present because he's in Japan training a bunch of selected surgeons. So thank you for your attention. And
Okay, so let's open up the floor for questions.
oops.
Anybody have any questions? Okay, so I have a question for Anne. I saw with interest the difference between SVC and ASCs, and how somewhat anti-intuitively you would expect the pure cultural cells to be more potent and work better, but instead we're seeing that a multitude of different cells seems to work together. What do you attribute that?
Yeah, absolutely. Within the SVF, there are only about 10% ASCs with the way that we isolate. I know there were differences between each of us, and this is because whenever we harvest adipose tissue from mice, there's a considerable amount of hair and such things that we have to filter out. But looking at our populations with 10% being ASCs in the SVF, the combination of the ASCs with the immune cells, I believe, is what makes it so potent for these neurodegenerative or autoimmune effects that happen in the body. So they target different areas. And I didn't get to show the data, but we used SVF cells and ASCs from GFP positive mice, and then they were administered to these EAE mice. And we were able to detect some GFP in the periphery, which were in the spleens and lymph nodes from the SVF injection, not ASCs. And then looking at the central nervous system, so these cells were intraperitoneally injected and they found their way, and usually you think of stem cells as homing to sites of pathology, but I would think of it more of sites of activity. So if the immune system's actively responding, and then also in the central nervous system, these are key elements that give us insight into what mechanisms that SVF uses that's different than ASCs.
Yeah, I agree with you. I think that SVF works in a different way, and it contains what we call amplifier cells to the signals, and are in many ways I think will prove to be better for certain conditions than ASCs. Bill, I saw your very impressive results with healing of diabetic feet. I was for 14 years I was in a wound care clinic, and I always could heal everything, but I could never keep it healed. And I think that with diabetics, the main problem is the neuropathy, which Now, did you happen to measure sensory function after SVF? Because I bet you there must be some kind of improvement after SVF.
We didn't in that study, but the patient, you're right, and I'll just report that anecdotally. There's an important part to what you just described, and that is not only did we inject under the wound, and we took angiograms, and so we took pre-op and post-op. And what you can see is under the wound where it was injected, you just see it blush. You just see vascular structure start to form. But we knew that these people were all compromised. So in the angiogram, we looked at the lower limb and we actually found the stenotic points as we walked down. And we injected around these points. And then we looked at them post-operatively, and you can actually see flowing vascular structure. So we have flow Doppler. And so to maintain, like you said, you couldn't keep them closed or keep them healed. We directly addressed the vascular supply. And that's what seemed to be, I mean, that's as much of, well, I can't say what percentage, but that's as much of the solution as injecting under the wound itself.
I was referring more to neural function, because then they get the neuropathic ulcers essentially, and but I do think, and I have heard from people who do stem cell therapies, anecdotally improvement in sensory function after stem cell injections, and I was just wondering if you guys are planning to measure that.
So we have another, these are what I would call at this point case reports. So these are people with neuropathic pain and no ulcer. And the pain was so bad that they were considering amputation. And they were injected, and their pain is greatly and significantly reduced. I wouldn't say all the way gone, but significantly reduced.
Great.
Where did you inject for neuropathic?
Down the back of the leg and the foot. So we looked at the vascular structure, and we found where it was narrowed and where there was, where the vascular feed was not strong. And so we would put injections of SVF with fluid all the way around. So there's like 15 injections going down the back of the calf. I have pictures where we're trying to lay it right down the arterial feed. And then in the foot as well.
Go ahead.
Hi, Mark Holterman, University of Illinois. Question for Ann. Did you guys study in your EAE model for IL-17?
No, we haven't. That's one of the mechanisms that we're looking into, the T cells and how they were differentiated.
Yeah, so in our studies, we see IL-17 go real high on that. So
Okay.
I predict it's going to be positive. And a question for Camillo. Have you looked at the immunomodulatory differences between mesenchymal stem cells growing flat on the plate versus lipogems? Is one better than the other?
Yeah, we didn't do comparative study. We're looking into some of this, but one of the impressive points that have been observed is like that in scleroderma, there is a trial ongoing in scleroderma that not only improved the aesthetic but also the vasculopathy disappears, and also in other studies in alopecia areata, which is also autoimmune, you have growth of hair again. So it seems there is definitely an immunomodulatory effect, and you can imagine we are looking also to test it on the biohub as an added strategy for islet transplantations to see if you can both promote angiogenesis and have some immunomodulatory effect. The intriguing fact is that depending how you use MSCs, we found, like, for example, when we inject them, we just published in Diabetes Care a clinical trial on 42 patients, randomized prospective, using MSCs expanded from umbilical cord, and it's like, if you see this effect on autoimmunity, and then you see a protective effect on islet rejection in other islet transplant preclinical model, but then if you expand those cells and you see them, for example, on a scaffold, on a silicon scaffold, that immunomodulation disappears. So it seems also that it's very important how you use it. It's not just the cell types, and you can have modification of the phenotype and effect depending how they are cultured. So we're very interested in all the preconditioning and how to learn which condition may be more conducive to the immunomodulatory effect.
Thank you.
Fortunately, we're running out of time. We just have more time for one more quick question.
Sorry.
Regarding your knee work, your knee joint work, were these just, how were the stem cell products delivered to the knee? Was this just intra-articular injection or either one? Y'all both?
Well, in our case, it's intra-articular injection, but you have to be careful. Recommended. I don't do this, but I know that I would want to have it done by an orthopedic surgeon with ultrasound guided to make sure that you know exactly where you go, because apparently the way you deliver these cells, and especially if you deliver too much of a volume, could be leading to undesirable side effects. So there is a table that has all the specific of volume injected for different conditions, but I know that I
So your study was ultrasound guided, as far as you know, as
Mhm.
opposed to fluoroscopically?
Or anyway, guided, instrument guided. I don't know exactly which one they
Some kind of
use, but-
imaging modality, okay.
So we used experienced orthopedic injections, and if you tap the knee and you can show that you can withdraw a little bit of synovial fluid, you know you're intra-articular. And so we would look for that, look for a cc or 2, and then the injection was between 3 and 4 cc's of lactated Ringer's with the dose of cells suspended in LR.
Okay.
All right, well, thank you everybody for coming to this panel. We're running over, so let's welcome the next panel.